Hello my dear friends and colleagues, I am back with a new video. Today we are going to discuss about amenorrhea. Amenorrhea means absence of menstrual cycles. Amenorrhea can be classified as primary amenorrhea and secondary amenorrhea. Primary amenorrhea is defined as absence of menstrual cycles by the age of 15 years in the presence of secondary sexual characters. There is a second definition in which we consider as absence of menstrual cycles in a girl by the age of 13 years in the absence of secondary sexual characters. Secondary sexual characters, they begin as growth spurt and thelarchy followed by menstrual cycles. So if these two things are not seen, then we have to start investigating by the age of 13 years. And if secondary sexual characters are developing, then we can wait till 15 years. So secondary amenorrhea, it is defined as absence of menstrual cycles in a woman for 6 months who has been menstruating regularly previously. It is also defined as absence of menstrual cycles for 12 months in a woman who had previously menstruating irregularly. That means she had oligomenorrhea previously. What are the causes? Broadly speaking, the causes for primary amenorrhea are gonadal dysgenesis, which is responsible for 47% of cases of primary amenorrhea. The most common cause is Turner's syndrome. The second cause is Mullerian agenesis. The commonest cause is Rokitansky syndrome. Third is a constitutional cause for primary amenorrhea, which is responsible for 14% of cases. Fourth is polycystic ovarian syndrome, which is responsible for a minority of cases, around 7%, because PCOS is responsible for secondary amenorrhea. The causes of secondary amenorrhea are ovarian causes, which is 40%, hypothalamic causes 35%, and uterine causes 5%. Now let us see the hormonal basis for amenorrhea. In the brain, the hypothalamus secretes gonadotropin releasing hormone, which acts on the pituitary to produce FSH and LH. This FSH and LH acts on the ovary. The ovary releases estrogen and progesterone, which is responsible for the formation and shedding of the endometrium and the normal menstrual cycle. If this is disrupted at any level, it will cause amenorrhea. WHO has classified this into 3 groups, group 1, 2 and 3, depending on the levels of estrogen, FSH, prolactin and the hypothalamo-pituitary ovarian axis. So group 1, where the defect is at high level. So there is decreased secretion of FSH, which in turn causes decreased secretion of estrogen. This is known as hypogonadotrophic hypogonadism. The second cause, where the defect is in the entire hypothalamo-pituitary ovarian axis, the most common cause is polycystic ovarian disease, where the estrogen is normal, FSH is normal and the prolactin also is normal. The third is the hypergonadotrophic hypogonadism, where the cause is gonadal failure. In this, there is decreased secretion of estrogen. Because of that, there is positive feedback and increased secretion of FSH. So there is high FSH and low estrogen. So this is known as hypergonadotrophic hypogonadism. Now let us see how we evaluate a case of amenorrhea. So in case of primary amenorrhea, we have to see for evidence of some psychological dysfunction or emotional stress in the girl, and we have to handle it in a sensitive way. We have to ask the history of some gynecological problem in the sister as well as in mother. We have to ask the family history of genetic disorder, diabetes mellitus, family history of delayed puberty, defect in the hypothalamo-pituitary ovarian axis, where there is lack of pubertal development, and the chromosomal cause like Turner syndrome. Then we have to see about the hirsutism virilization syndrome. In this, we have to see for any androgen secreting ovarian or adrenal tumors, or 5-alpha reductase deficiency, congenital adrenal hyperplasia. We have to ask about evidence of hypothyroidism, galactorrhea, history of anosmia, history of weight loss, headache, visual symptoms, polyuria, polydipsia. If she is sexually active, then there may be some problem with the sexual activity because of imperforate hymen or transverse vaginal septum or the blind vaginal pouch, which is seen in androgen insensitivity and MRKH syndrome. There can be chronic illness, previous malignancies, and history of radiation or chemotherapy. So this is about primary amenorrhea. Let us see how we will evaluate a case of secondary amenorrhea. The first and the foremost investigation is urine pregnancy test. This is the mandatory test which we have to do in a case of secondary amenorrhea. If she has irregular cycles, then we have to see the polycystic ovarian syndrome. If she has breast secretions, then we have to think about history of hyperprolactinemia or prolactinoma. We have to assess her thyroid function. If she has history of headache, then there can be some intracranial lesion which is responsible for amenorrhea, like craniopharyngiomas, gliomas. History of head injury is there, then it can cause some ossification, heterotopic ossification in the brain. History of previous pregnancy followed by excessive bleeding is a cause for Sheehan syndrome. History of previous miscarriage and dilatation curettage can lead to Asherman syndrome. And then previous medications like some contraceptive medications, antipsychotic medications are to be considered. So this is all about the evaluation of a case of primary and secondary amenorrhea. The other causes of amenorrhea we will discuss in detail in the next video. So if you like the content of this channel, please subscribe to my channel and don't forget to hit the like button and share with your colleagues. Thank you.